Thank you.
I now recognize Dr. McCormick from Georgia for 5 minutes of questions.
Thank you, Mr. Chair. Director Welensky, it's good to have you here today. Thank you for being with us. It was funny, I was just talking to Dr. Howery today, who is my old attending at Grady and Emory when I was a resident. I will say also thank you for your service during the pandemic. I too was on the front lines of this pandemic from the very beginning, all the way through December of this last year. So watched the entire evolution of this disease process with dismay at times that we politicized it so much. As a matter of fact, I would make the case that probably the biggest mistake in this, I'm going to ask your opinion on this in a second, the biggest mistake maybe we made of all the different things, the different guidances and everything like that, that's all fine. I think we did our best. But the biggest problem is, and a lot of people point this out all the time, is we let this become political rather than medical, rather than a healthcare question, whether instead of letting doctors talk to their patients about this, we had politicians talking to prompters. You had people who had access to you to try to give you input, did, whatever, it doesn't really matter, rather than doctors. I remember Jerry Williams, a doctor out who's an urgent care physician who treated thousands and thousands of patients with great success. Wanted to have access but couldn't get access, but a teacher's union gets to have your personal cell phone number. I think that's egregious because it became political. I think you're a scientist. I think you're a person who understands an infectious disease process. Do you think that the biggest problem, I think the biggest problem, and I'm going to ask you if you think this is the big problem, the biggest problem with all the misinformation, with all the fact that we had black liberals and white conservatives both mistrusting this disease and not doing the right thing, a lot of times not following the science, because both sides were politicized so bad that nobody could figure out what the truth was anymore. Because it was politicized, we couldn't get to the truth. Would you agree that was one of the biggest problems we had with this disease?
Yeah, I would say that, first I want to say that many scientists and state health officers, I have given every one of our state health officers my direct cell phone at some point in time over the last 2.5 years so that they had access to me too, so that they could see what was happening on the ground. So that was not that was a frequent event that people would have access to me. I do think that when politics have become involved in what we are trying to frame, what it should be framed as a medical health measure, we get mis and disinformation, we get vitriol splashed across the pages of public health workers doing the hard work of public health. We get threats to our public health workers that limit what they are able to do and have them have fear in terms of doing their job and doing it properly. Poor press, I think all of this is politicized and frames a really difficult situation to trying to do our best in health and public health.
One of the things that was interesting is I too was threatened with my license. I did get censored as a physician who treated thousands of COVID patients by people on the internet, by people in government, telling me I couldn't express my professional opinion as a doctor and as a scientist. Ironically, it goes full circle, and it came once again from the politicization of this, where people thought they were experts based on I'm powerful, rather than I actually know what I'm talking about. And ironically, the things they censored me on, I turned out to be correct on. They wouldn't even allow a dialogue of medical professionals to actually debate the science on a national scene, rather than just one size fits all, we're going to let the government decide what's truth. And this is the problem I have with this. You mentioned during the opening statements, you said, or actually during the open question, you said that we didn't get information on vaccinated hospitalizations, which surprised me. I thought we did have some of that. I imagine that also carried over to ICU visits and probably deaths too, because if we don't have that.
Just to be clear, we don't have that at a national level. We at CDC collect data in cohorts so that we can follow that for vaccine effectiveness studies. But at a national level, we get hospitalization data, we get hospitalization for COVID data, but at a national level, we have never been able to get hospitalization, vaccination, and COVID.
Yeah, so that worries me because it seems to skew the data. And I see you nod your head, yes, I agree.
Well, I think it just speaks to the real challenges in our data flows and our ability to give data back to the American people when we don't have full line of sight of all the data that people are interested in.
Couldn't agree with you more, which I spent so much time, every time I admitted a patient, every time anybody was tested for, I filled out an egregious amount of EHR paperwork in order to answer every question before I did any treatment or any admission. And yet, we never collected data on one of the most important statistics of all, which is vaccinated patients and the effectiveness of hospitalizations versus ICUs versus deaths. It wasn't a fair conversation. It seems like that was avoided. Were you asking for that information, or was that just something that they didn't want to collect?
So, Dr. McCormick, let me just be clear. We were looking at that in our vaccine effectiveness cohorts, in our VISION and IV cohorts, so that we could report that out on vaccine effectiveness data. We were looking at that because we knew that that was critically important. But I do want to emphasize that we did not get data in aggregate. We are, again, just to be clear, we're not looking for PII here. We did not get data in aggregate on vaccination and hospitalizations. All that data that you're filling out in the EHR does not translate into public health data. And that is really why I've said our data highways are so clearly important if we are going to report on what is, on the outcomes that people are asking for. And our data authorities are so clearly important so we can present those data in aggregate.
And what's interesting is how much money we spend on that EMR or EHR every single year, billions, tens and tens or maybe hundreds of billions of dollars, collecting information that you can't get a hold of.
And maybe if I could just say it again, hundreds of billions of dollars. We've gotten less than $1 billion for our data highways across the country, 3,000 health departments for our data modernization initiatives.
All right. Are you aware of the must-admit orders that some states, including New York, were using to send COVID-positive patients to nursing homes early on in this disease process?
You'd have to say more. I'm not sure.
So remember when we first had this pandemic started, we didn't really know a whole lot. We just knew it was contagious upper respiratory infection. As an infectious disease, by the way, this is not in the capacity of a CDC director. This is capacity of an infectious disease doctor. We're talking doctor science here. They had originally the must-admit orders that some states were using in order to push patients who were positive for COVID back to the nursing homes. Are you familiar with that?
I'm not familiar with that.
Okay. Would you say it was a good idea to send infected COVID patients back to the most vulnerable community of all, which is nursing homes?
I can't speak to that. I was not aware of that. What I can, because what was the counterfactual? What was the alternative of them going there? What were the mitigation strategies there? Did they have singular rooms? So I think that there are a lot of parameters that would affect my answer to that question.
I think you might be a better politician than me right now. But I would say that if you were to be a scientist...
I am a scientist.
And to be a doctor who is talking about putting infected COVID. Now, I know how much time we spent and effort we spent separating our patients at the hospital, the COVID patients from the people who are not positive. And I would say, I'll just make the statement for you, it's a bad, doggone idea to send infected COVID patients, one of the most deadly diseases, as you've stated, back to the most vulnerable populations of all by direction of the state, by their legislative actions. And with that, I yield.